Dear colleagues, we are very happy to be here for this very exciting session on fluid resuscitation. I am Stéphane Gaudry from France, and I'm pleased to co-chair this session with Lise Piquillou from Switzerland, Lausanne. And we have now the first talk from Jan Bakker from Brussels on this hot but old debate, restrictive versus liberal strategy. Thank you very much.
Thank you. Good morning. So indeed, it's really outdated. And I will make the point with you. We know from observational data that we have indeed a sweet spot where we can, in many of these patients, try to identify what is the best amount of fluids that we have to give to our patients. Too much is not good, and not enough is not good either. And these are more recent data showing you exactly the same pattern in large database. You can observe that indeed there is some amount of fluid that seems to be best fitting your patient. So, of course, it's not easy to know where to go, and there have been trials comparing the liberal versus restrictive management. And I want to go with you into these trials to try to understand a little bit what is behind it. And of course, we have this very important trial, the classic trial that indeed show no difference in outcome at any time that was observed here. And more recently, the Clovis trial, which was also totally identical outcome here on survival rate, but also for vasopressor-free days, for ventilatory-free days, and for acute kidney injury incidence. So absolutely neutral study. And of course, we have to put a little bit this in opposition, perhaps, with this trial from the RSNet, the FACT trial, that showed, yes, no major difference in survival rate, but yes, the patients were breathing more rapidly without assistance here. Importantly, again, these patients were included roughly 42 hours after ICU admission when they were stable or stabilized and no more in shock at that time. And more recently, even in acute kidney injury, trying to be restrictive or liberal did not have major impact on any of the features here. So, okay, no major difference, so we don't care. And indeed, if you do the meta-analysis of these kind of trials, you end up by absolutely no signal there, and so this means that we do not care. Well, this may not be exactly the same, because indeed, if we look at this, if you are looking at this as a pure methodological aspect, you may say, well, I can be liberal or I can be restrictive. It doesn't care. So I do what I wish to do. Well, this is not exactly where we should do, because indeed, this would imply that Monday I will go liberal, Tuesday I will be restrictive. Is it wise? Probably not. Because probably, if we look more deeply in this trial, some patients benefited from being, let's say, liberal, and some patients were harmed by being liberal, and vice versa, of course. And this is much more a problem. Because yes, indeed, if you look at the details here, of course you may say, well, there is no... Okay, but if you look at the signal here, as you may perhaps expect, when your patient has more severe lung disease, guess what? It's better to be restrictive. When you give a lot of fluid before, it's also better to be more restrictive. And when you are giving not enough, surprise, it's better to be more liberal. So indeed, you need to adapt to the patient. And of course, just doing like this is not very good. So a per formula prescription for everybody is not the way to go. We need, of course, to individualize. Individualizing, because indeed, that's what we do in our everyday practice. And not just for medicine. Just look at, yes, when you select your shoes, do you go for a big one or a small one? No, you go for your own size. And if you randomize doctors to run with some shoes, you can realize that maybe with smaller one you can go faster. Yes, but you will also get some injuries on your feet. So yes, guess what? When you go for selecting your shoes, you take the right size for you. So maybe for giving fluids to our patient, we take care also by taking the right size. And basically, all patients do not behave the same. It was taking 10 years for the EFFACT trial to suddenly realize that all patients were not equal in that trial. And yes, some patients were indeed benefiting for being conservative, but also some patients were harmed by being conservative. And the same was true for other aspects. Here in septic shock, you can also see that you can find some ways to identify some patients who will benefit from being more liberal and some patients be benefiting from being more restrictive. So basically, it's not being liberal or restrictive, which is outdated. This is really a way of thinking how to be liberal in some patients and restrictive in other patients. And for this, of course, we need to individualize. And in our guidelines of ES-ICM on fluid management, and this will appear soon in ICM, we are really very clever not to make any recommendation on being liberal or restrictive. We couldn't say, oh, just do, both are equally good, so do what you wish. No, we don't say this because it's too dangerous, because in some patients will be benefiting from being liberal, being restrictive in these patients can be harmful. So we need indeed to identify the patient and to select the good option for each of the patient. And that's what exactly we say here. We should be individualizing our approach here. Okay, how to individualize? Because this is even more complex, of course, and for that, we may think at looking at the patient. And indeed, from the Clovers trial, the patients were with severe kidney injury. These patients, guess what, benefiting from being more restrictive. Of course, you may think at that factor, and you may also think at other factors. Probably we may anticipate what could have been the losses. In a patient with gastrointestinal disease, often there are a lot of losses because you lose some fluid in the stools. It's not the same if you have respiratory sepsis, of course. Also, tolerance to fluid, as mentioned in chronic kidney disease, but also according to cardiac function, maybe the PF ratio, other factors may need to be taken into account. And also, of course, pay attention to what was given by your colleagues before you take this patient in front of your eyes. So yes, we need to individualize, and for this it's probably better to measure what we do, and so indeed apply some hemodynamic monitoring to these patients. And the first aspect is that it's not being liberal or restrictive, but we need to have an indication. And for that, we need to have a problem for which we think giving volume will be the solution to improve the patient condition. And for that, we need also to take into account a very good index, which is quite dynamic. Because when tissue perfusion is already normalized, even when lactate remains elevated, then you realize that in these conditions, you give more volume, and you end up by an increase in mortality in these patients. So yes, impaired tissue perfusion is an indication, and when it is normalized, probably you should not give more fluid in these patients. And then, of course, test whether a patient will respond or not. We have a lot of tests we can take into account, of course. The heart-lung interaction for these will be developed later on. Relatively good performance of various tests. Maybe some interest of combining tests, of course. And also, you need to take into account the fact that in some conditions you may apply, and some other conditions you may not apply a specific test. Also, the positive test, we will not discuss this later on. The most important aspect, you predict whether a patient may respond, then you also need to evaluate whether it is really effective. And for that, you need indeed to do the fluid challenge. It's not a prediction, it's an evaluation of the efficacy of the fluids. And you have several ways to look at this. But importantly also, you need to look at the tolerance of fluid. And indeed, remember that initially what you have, you increase the volume, diastolic volume of the heart, and on the steep part, you increase stroke volume. But then at some point, on the flat part, you don't change anything to the stroke volume, but also we have a marked increase in the pressure in these conditions. And remember also that the patient with increased permeability will be at risk for a lower volume, a lower pressure, to have more leak to the respiratory system. So again, you need to adapt specifically to the patient there. And also adapt for the cardiac condition of your patient, because indeed, the patient with impaired cardiac function also have a higher pressure, so a higher leakage for a given volume. We also need to take into account what occurs outside the thorax, and indeed, CVP and other aspects are the back pressure of the perfusion to the organs. And so venous stasis is important, and we know that the higher the CVP, the higher the risk to develop acute kidney injury. But this is not only just the pressure, you can also look at the morphology of the flows, and indeed this is quite new ways to look at it with ultrasound, and you can do this in the hepatic vein, but also in the femoral veins, perhaps sometimes more easily accessible than some others, and that indeed the pattern there is totally different in patient tolerating fluids and patient not tolerating fluids. And that's quite important because at some point, of course, your prediction was your patient will respond. The patient effectively responds with minimal price to pay, and this is really the optimal response to fluid. Sometimes your prediction was not totally right, and your patient fails to respond to fluid, and that's really time to stop giving fluid in this patient. Then you have, of course, the intermediate response. You do not know well. Maybe you can try again, and this is the most complex situation. You have an increase in flow, but unfortunately, the price to pay is quite expensive. Do you continue in that direction? Do you change the option next time? Well, this is really something for which we need a brain at the bedside. We need a brain at the bedside to really assess the situation there. Sometimes you have complex situations where you have also indeed this kind of response to fluids and the stasis that is detected by ultrasound. And this is why, nicely summarized here in this domain here, you have indeed the expected benefit and the expected harm that can be evaluated by indices of fluid responsiveness on one hand and indices of fluid congestion on the other hand. The best case scenario is, of course, this one. But here we are more in doubt what to do. And of course, here we know that there is no benefit, so we should not go in that direction also. So we need really to assess the benefit risk at the bedside. Something else we need to pay attention is the fact that we focus a lot on prediction of fluid responsiveness, but most of the fluids we are giving is not really this one, because indeed, you can see that the non-restrictive fluids are really quite a large amount there. You may try to restrict this. This was done in this French trial, and they were able to indeed limit quite nicely the amount of fluids that they give there. Again, no real change in outcome in these conditions. So maybe it can be done, but we need to be cautious. And of course, minimizing non-restrictive fluids is quite easy if we are thinking at maintenance fluids. Dilution of fluids, it's a little bit more complex, and you need to think at it with a few aspects there. Because indeed, one very important aspect is that in most of our drugs, we have indeed dead space. And the dead space in our line should be, of course, not too high compared to the dilution we give. And so if we give one antibiotic diluted in 100 or 50 milliliters here, you can see that here it begins to be a loss of the antibiotic, which is quite important. Maybe that's not desirable. And so we need also to minimize these kind of things because antibiotics and maybe other drugs are quite essential for our patients. And also, finally, we need to pay attention to the sodium content because indeed, when you give a lot of sodium, this will lead to a lot of accumulation of water in the extravascular compartment. And this needs, of course, to be minimized, and this is also something important. So at the end, yes, the debate is totally outdated. And we really have to think that it's probably dangerous to be either liberal or restrictive in every single patient. We need to really optimize, individualize the fluids based on the evaluation of the requirements, mostly driven by perfusion indices, use fluid responsiveness whenever possible, evaluate the response to fluids in terms of benefits, but also in terms of tolerance, and try to minimize the non-restrictive fluids and sodium that you give in these conditions. And with this, I thank you for your attention.
Thank you very much, Dr. De Bakker. Is there any question in the audience? Okay, just 1 minute. I would like to know if, do you know some artificial intelligence tools to know which patients will benefit for a restrictive or liberal approach in fluid resuscitation?
These are not available. I mean, but of course, there is a publication of Romain Perracchio on that a couple of years ago. The interest, of course, that this kind of evaluation of retrospective data can indeed show us that the computer may have done differently, and that perhaps it could be associated with a better outcome. The issue is really that we need to know whether applying this prospectively can really be beneficial, because what we just say is that the physicians were not always good in their choices, but we cannot really state that other choices would have led to a better outcome, of course, in these conditions. But it's probably wise to try to find ways to identify who would benefit best from fluid from those who will not benefit from fluid. And I think that, yes, that's a way to go, because this can be done with minimal measurements that can be available. But of course, we need the systems in all our ICUs, including in India, including in Brazil, including in many places where resources would be more limited.
Thank you very much. Is there another question? Okay.
Thank you.
Thank you very much, Dr. De Bakker.
I have now the great pleasure to introduce Professor Sheila N Myatra from Mumbai, India. And the title of her talk is Should We Predict Fluid Responsiveness in Everyone?
Good morning, friends. Thank you very much. I have no conflict of interest for this presentation. I'm going to just discuss what we mean, the concept of fluid responsiveness, what are the tests, and should we be predicting it in every patient? Now, this is a recent study from Antonio Messina and Maurizio Cecconi, and they've looked at fluid responsiveness, fluid challenge over a long period of time, 2 different periods, and they've actually shown that almost half the patients to whom we give fluids are not really fluid responsive. Now, does it make a difference? This is again another paper from the same group, and almost 25% of the fluid that we give to these patients are given in the first day, and a positive fluid balance is associated with mortality. So it's not something that we can take very lightly. And I'm sure you will all agree that apart from the initial fluid resuscitation, determining which patient is going to be fluid responsive is really a challenge on the intensive care unit. Because on one side, you want to restore the organ perfusion and you want to give volume, and on the other side, you don't want to push the patient into pulmonary edema. So when you ask yourself this question, should I be giving fluid to this patient? What you really want to know is that by giving fluid, is the cardiac output or the stroke volume going to increase? Because then there's a benefit, and if not, you're just giving fluid and it's actually not going to benefit the patient and might actually cause harm. So when we say fluid responsiveness, what we mean is a state when administration of fluids will actually lead to an improvement of stroke volume. So we look at about 10 to 15% increase in the cardiac output when we say a patient are fluid responsive. Now, when I decide, should I give fluid or not, I ask myself 3 questions. Is this patient in acute circulatory failure? Is the patient fluid responsive? And most important, is there any major risk of giving fluid? If my answer to all three questions is yes, then I would go ahead and give fluid. Because even if this patient is fluid responsive, if there is a risk of giving fluid, I might consider not giving fluids and initiate vasopressors. So let's just try to understand that how do we commonly assess fluid responsiveness at the bedside? Now, if you look at the last iteration of the surviving sepsis guidelines or the ESICM guidelines on fluid administration, acute circulatory failure, and I was very fortunate to be a part of that, they suggest that you use dynamic oversat parameters to predict fluid responsiveness. That means we should know even before giving fluids whether this patient is a fluid responder or not. Now, what are these tests? Now, most of them are based on heart-lung interactions, looking at PPV, SVV, a new test called tidal volume challenge, end expiratory occlusion test, PEEP test, some lung recruitment challenges, and most of them depend on heart-lung interactions, but there's one test that does not depend on heart-lung interactions, and this is the passive leg-raising test. All of you know the passive leg-raising test from the group of Professor Monet and Professor Teboul, a very useful test, and of course there are limitations. If the patient has raised intra-abdominal pressure or neurotrauma, you may not be able to perform this test, and there's a very nice meta-analysis of all the studies which have shown a good reliability of this test with a cutoff value of a 10% increase in cardiac index to predict fluid responsiveness, and therefore you need real-time cardiac output monitoring, but you could also do this with echocardiography because 10% is sort of the cutoff range for using echocardiography to look at cardiac output. Then you have pulse pressure variation and stroke volume variation. And both of these are continuous and they come as a value on the monitor. And, if you use pulse pressure variation, you only need an arterial line. You don't need continuous cardiac output monitoring. But of course, they have limitations, several things that can cause false positive and false negative values. But the most important of this are the use of the low tidal volume. And today we use low tidal volume not only in patients with ALI, ARDS, even trauma, sepsis. Those of you who have anesthesiologists, even in the operating room, we're very, very gentle on the lung. So very reliable test, but not useful when the tidal volume is less than 8 ml per kg. And this is a very nice recent paper from Professor Jan Bakker and Xavier Monet and Michael Pinsky, and they looked at the tests where you could use the ventilator to predict fluid responsiveness. So you just tweak some buttons, of course it has to be an intubated patient, on the ventilator, and you could use it to discriminate patients who are responders and non-responders. And the three tests they described are the tidal volume challenge that was developed in our unit, the end expiratory occlusion test, and the PEEP test. So I'll talk about the tidal volume challenge. As I mentioned, pulse pressure variation and stroke volume variation are not reliable when the tidal volume is less than 8 ml per kg. So, you have a great test, but doesn't work when the tidal volume is less. So should we throw the baby with the bathwater? In our unit, we hypothesized that, okay, this test doesn't work when the tidal volume is less than 8. So why don't we transiently increase the tidal volume from 6 ml per kg to 8 ml per kg, and then look at the pulse pressure variation? And we developed a new test called the tidal volume challenge. And as we expected, at 6 ml per kg, if you look at the area on the curves, the test was not very reliable. When we increased the tidal volume to 8 ml, as we hypothesized, it was quite reliable. But to our surprise, what was even better than the value at 8 ml per kg was the delta, that is the difference between the tidal volume at 6 ml and 8 ml per kg, the pulse pressure variation. And we got cutoff values of 3.5 and 2.5. And I'll just demonstrate how easy it is to do this test when you use pulse pressure variation, because all you need is an invasive arterial line. You don't need a cardiac output monitor. So here you can see the ventilator on the left side. Patient has an idle body weight of 45 and therefore is ventilated at 6 ml per kg with 270 tidal volume. You can see the pulse pressure variation is 8. And now I'm increasing the tidal volume from 6 ml per kg to 8 ml per kg. That's 360. And we do this only for 1 minute. And then you look at the pulse pressure variation. And, you see that the pulse pressure variation, we started at 8. From 8, it has increased to 10. And from 10, it has increased to 13. As I mentioned, you don't do this for more than 1 minute. And after 1 minute, you need to bring the tidal volume back to the baseline. And as you can see, the tidal volume has now become, pulse pressure variation has become 15. I will bring the tidal volume back from 360 to 270, that is 6 ml per kg tidal volume. And how do we make the interpretation of this test? So that I'm bringing the tidal volume back on the ventilator. So you just do this for 1 minute. Now, how do we interpret this? Now, you started at 8. Pulse pressure variation, it became 15. 15 minus 8 is 7, and this is more than the cutoff value of 3.5. So this patient is a fluid responder with a good specificity and sensitivity. And if this is a non-responder, you'll have something like it moves from 8 to 9, comes back to 8. So it's really, really very sensitive. This was a proof of concept study that we did in our unit, and we developed the test. But subsequently, there have been several studies that have been performed. Now we have a meta-analysis of studies looking at this test, showing good reliability with this test. And moving to the next test, that's the end expiratory occlusion test. And this comes from, the group of Professor Monet and Professor Teboul. And this is a very smart test, again, using heart-lung interactions and using the ventilator to assess fluid responsiveness. And what you do is you give a 15-second expiratory hold. And when you release the knob of the button, you will have a sudden increase in the preload. And if there is more than a 5% increase in the cardiac output, this patient is likely to be a full fluid responder with a good specificity and a sensitivity. Now, unlike the passive leg raising, where the cutoff was 10%, this is only 5% increase. So you need real-time cardiac output monitoring. You cannot do this using echocardiography because, for echo, you should have a difference of at least 10%. They have a very nice meta-analysis of the studies that have looked at this, and you can see good area under the curve, and 5% is the cutoff values. Of course, you need an intubated patient, and you need real-time cardiac output monitoring to do these tests. We have also echocardiography, and there are different ways that we can look at it. Transthoracic echocardiography is now, it's like the new stethoscope in the intensive care unit, and you don't even need lines to perform this test, and there is a short learning curve. However, if you look at the multicentric trial that has compared all the echocardiographic variables to predict fluid responsiveness, the reliability of this test is actually least among all the tests to assess fluid responsiveness. So, when you look at the commonly used tests to predict fluid responsiveness, these are the ones that are well demonstrated. The least reliable, as I mentioned, is the IVC variability. They're relatively easy to perform. Of course, passive leg raising, you need to perform a maneuver, and IVC collapsibility, there's a bit of a learning curve. The least applicable is PPV and SVV in several conditions. Passive leg raising, because it doesn't depend on heart-lung interactions, can overcome most of these limitations. And you don't need cardiac output monitoring when you use PPV, SVV, or tidal volume challenge, and also IVC variability. So how do we look at these tests now, and do we need to really do them in all patients? So these are the attendees that are at the ISICEM meeting. Now, most of you will be fluid responsive. The normal human heart is fluid responsive. But does that mean we need to assess fluid responsiveness? What's important is you need the presence of acute circulatory failure. So there's no indication to assess fluid responsiveness in the absence of circulatory failure, of course. Now, what about initial and subsequent resuscitation in a patient? Now, this is from the Andromeda study from Glenn Hernandez, as you all know. Now, in this study, at the time of randomization, they assessed fluid responsiveness in about 80% of the patients. And interestingly, 70% of them were fluid responsive. And already about an average of 2 liters of fluid had already been given to this patient. So most patients are fluid responsive during initial resuscitation. And here you will see that, subsequently, of course, the fluid responsiveness status decreased. So fluid responsiveness can actually be avoided prior to initial resuscitation. Irrespective of the types of shock, most patients are likely to be fluid responsive. Now, if you look at the last iteration of surviving sepsis guidelines and you talk about the initial fluid responsiveness, 30 ml per kg is a recommendation over 3 hours. That's a long period of time. The good thing is that this has been down-regulated from the previous iteration to a suggest rather than a recommend. But imagine initially giving such a large volume of fluid to someone who may be a non-responder. And this is a very nice paper that was led by Professor Vincent, and I was a part of this along with other co-workers. And we talked about how we could equilibrate this and individualize the care in this kind of situations. We gave about 20 recommendations, but I'll talk about the one we gave on fluid administration, initial resuscitation. And you cannot equilibrate a young individual with no comorbidities with an elderly gentleman and talk about a one-size-fits-all giving 30 ml fluid. So you should individualize this, and this is a very nice paper where you could individualize the initial fluid administration and still remain within the framework of the surviving sepsis campaign guidelines. So So instead of giving 30 ml, you can perhaps give 10 ml per kg, and then you can assess the response, okay? If the patient's lungs start getting worse or he starts desaturating, you might consider stopping. Where in other patients, if shock persists and they're doing okay, you might consider giving more fluid after assessing fluid responsiveness. And I just want to go ahead with the case. Now, what about subsequent fluid management, okay? So this is a patient with a CA colon, inferior wall MI, febrile, elevated white cell count, tense abdomen, perforation. 3 liters of fluid have already been given in the ED. He's hypertensive, hypotensive, tachycardic, lactate is elevated, CVP is elevated, okay? So this is not the initial fluid management where you know, okay, this patient is likely to be fluid responsive and I'll give some fluid. Now, how many of you would want to give fluid, more fluid to this patient who comes to your intensive care unit? Please raise your hands. Nobody wants to give fluid? How many of you don't want to give fluid to this patient? Okay, there are very few people raising their hands. You've got to do something. So let us look at this more objectively. Should I give fluid to this patient? So there are reasons to give fluid to this patient. There's intra-abdominal sepsis, relative hypovolemia, there's sequestration of fluid in the bowel, this is perforation, persistent tachycardia, and at the same time, the CVP is high, you've already given 3 liters of fluid, and there is this cardiac history. So this is the kind of dilemma that we face in the intensive care unit. We don't know after initial resuscitation whether we need to give more fluid or not, and this is definitely a situation where we need to assess fluid responsiveness. The other situation is the risk of fluid responsiveness, a risk of fluid administration. There's a very elegant paper which was led by Professor Jan Bakker, I urge you to read this paper because there's some very useful information there. And this is one of the graphics from the paper that talks about the interrelation of the vascular pressures, the extravascular lung water index, venous status, and you can look at the pressure volume curves and you can see the steep rise in the curve when there is impaired cardiac function and both your venous status, extravascular lungs all increase. So you need to look at the risk of fluid administration. Now, should we be assessing fluid responsiveness when there's a risk of fluid administration? Well, I would say yes. You need to look at the harm and benefit. You really need to look at the clinical context, okay? What is the age of the patient? Are there comorbidities? What is the PF ratio? What is the cardiac function? Is it that, if I have abdominal sepsis, what is the origin? It's not the same as if I have a pneumonia. And what is the degree of fluid responsiveness? Is it just 15% or is it 30%? What is the response to the initial resuscitation? I gave some fluid and, he actually developed some CREP. So, and even whether he's intubated or not, because the patient is not intubated, I don't want to give him fluid and push him towards a state of when he's intubated. So the risk of fluid administration really needs to be put into the clinical context. For example, both patient A and B are at a risk of fluid administration. But if you look at patient B, he's elderly with comorbidities, severe ARDS, has cardiac dysfunction, and is extravascular lung water and PVI. So even if these two patients have the same fluid responsiveness status and are both fluid responsiveness, I would be very wary about giving fluid to these patients. But I would still assess fluid responsiveness because it would give me some idea, because not all patients are the same. And remember, assessing fluid responsiveness doesn't mean that we need to give fluid to these patients, right? And this is a very nice paper that shows, from the Professor Teboul, that shows that you can even use assessing fluid responsiveness prior to fluid removal. So these are patients on RRT in which they gave, did fluid responsiveness testing, and you can see that those patients who were not hypotensive were not fluid responders at the end of the patient, this thing. So assessing fluid responsiveness can be useful for fluid responsiveness to predict hemodynamic intolerance as well. So I'd like to end with my take-home message that fluid responsiveness should be assessed in patients with acute circulatory failure, not all patients. After initial fluid responsiveness administration, fluid responsiveness should be assessed before you give subsequent fluid administration, because not all patients are fluid responders. And the presence of fluid responsiveness does not mean that we need to give fluid. It's just one part of the question. It just tells you that this is a fluid responder. Whether you give fluid or not is, again, a clinical decision. And assessing fluid responsiveness may be useful also prior to fluid responsiveness. And most importantly, no test or tool is perfect, and you need to integrate the various dynamic indices and your clinical assessment. I'll just leave you with our recent paper on the minutes bundle, and it talks about the initial management of fluids in undifferentiated shock. And with that, I thank you very much for your attention.
Thanks a lot, Sheila, for this wonderful talk with very clear messages. Are there questions from the audience? Yes, there is one here. There are microphones.
Thank you very much. Great talk. Just a curiosity, what would you define as a circulatory failure? I mean, in your opinion, which are the 2, 3 clinical signs or laboratory signs that I have to assess at the bedside?
Right.
Thank you.
So first would, of course, be clinical. So you look at perfusion, right? So I would say when you're looking at any patient, when we're saying acute circulatory failure, again, we mean shock. We look at 3 clinical windows, right? We look at the skin, we look at the tissue perfusion, we look at maybe capillary refill time, mottling, all this. We look at the neurological windows, what is the mental status of the patient, we look at the urine output. So this clinical assessment of the 3 windows are very important, and you have various biochemical tests that you can use. You can look at the lactates, and of course there are the hemodynamic variables, there may be hypotension, tachycardia. So these are the things that you would use to determine whether the patient is in acute circulatory failure. So having a normal blood pressure is not enough, because that's not a very good marker of tissue hyperperfusion. So you really need to look at whether this patient is in shock using both clinical and more objective parameters.
Another question, and maybe a second one. In your practice, do you prioritize one test or the other to assess fluid responsiveness, or do you do both the one with tidal volume at 8 milliliter by kilo and the end expiratory test, with the risk of having different answers?
Yeah, thank you very much. I think this is a very important question. And we integrate all these tests at the bedside. We use a combination of this test. No test is perfect. So initially, when the patient comes in and has no lines, there's point of care ultrasound. You do your heart and lung ultrasound very quickly. After we have lines in, I have an arterial line in, patient is intubated, I may use tidal volume challenge, I may use end expiratory occlusion test. These are reliable when the patient is on controlled mechanical ventilation. When I put the patient on spontaneous mechanical ventilation, if I have, I could use the passive. These tests are not reliable, PPV or, even tidal volume challenge. Then I would use the passive leg raising test, because that is reliable even during spontaneous breathing and can overcome the limitations of most of these tests using heart-lung interactions. So I would use this with echo, or if I had cardiac output monitoring, I would use PLR with the cardiac output monitoring. So the point being, you can use a combination of this when you're managing shock, and it's not just one test that you should use to manage these patients.
Thank you very much once again.
Thank you.
Dr. Myatra. So the next talk is how can echography guide fluid challenges by Michel Schuh from Sweden. Thank you very much.
Thanks very much. So it's always a hard call to come after Sheila, but I'm going to do my best. So ultrasound to guide fluid challenges. 4 disclosures to make unrelated to this lecture. Fluids are not always bad, Fluids you do need to improve cardiac output in order to improve tissue perfusion. However, we know that it's only effective in 50% of cases, and at worst it causes harm. So echocardiography can help you in all 4 phases of hemodynamic management. And by that I mean the salvage phase, the optimization phase, the stabilization phase, and the de-escalation phase. And I'm just going to go through this slowly one by one. So, in the salvage phase, as Sheila mentioned previously, this is where you would not spend time doing a full-scale echo. This is when you would do a focus, transthoracic or transesophageal, if you have that at your unit, to basically confirm or refute diagnosis, to understand the causes of undifferentiated shock, and importantly, when it comes to fluids, to rule out those pathologies where giving fluids will be deleterious. So probably easiest to illustrate this by showing you a few echo loops. Now these are all patients in shock. This is a 20-year-old man with diabetic ketoacidosis that looks hypovolemic to you, those 3 clinical windows. And you would use ultrasound not to give fluids. You would start fluids in this gentleman, but you use ultrasound to confirm hypovolemia by looking at the ventricular sizes. This is a small left ventricle. It is hyperdynamic. There is no dilatation anywhere. This is a 63-year-old lady who comes into you with abdominal pain and other non-specific symptoms, and you don't really find anything except maybe some discrete elevation in lead 3 of your ECG. And here you would see that the right ventricle is dilated and the septal and posterior hypokinesia, and the whole right side of the heart is hypokinetic. So this is somebody in shock that you may reflexly give fluids in the ED, and this happens all the time, but this is somebody in which fluids would be clearly deleterious. This is a 50-year-old man with protein C resistance. He comes in dyspneic and in shock. And here there is a thrombus. At the apex, you will see that the right ventricle is dilated, so is the right atrium. But importantly, you will see that the intra-atrial septum is bowed towards the left, as is the intraventricular septum impinging on left ventricular function. So this is why this person has low cardiac output, and possibly also there might be a patent foramen ovale that might explain his hypoxemia. So this is clearly another situation where you would not give fluids in that initial salvage period. And finally, this man with a 3-week history of flu-like symptoms walks into your ED and tells you, I'm not feeling well, can you give me some antibiotics? He's slightly dyspneic, and your echo shows a huge pericardial effusion. Don't be distracted by the size of that effusion, because size doesn't really tell you whether there is a tamponade or not. What you'd want to do is look at the inferior vena cava, looking for IVC plethora, a fixed dilated IVC, telling you that this is tamponade or impending tamponade. Fluids are not going to help, and this man needs a drainage of his pericardial effusion. So that was the salvage phase. What about the optimization phase? You've managed the patient in the initial phases of shock. In the optimization phase, you would use echo to assess the therapies that you have instituted. It could be vasopressors or inotropes. I'm not going to talk about that here. I'm going to talk about fluid challenges and fluid responsiveness, because the goal here would be to assess the adequacy of your fluid resuscitation and to assess ongoing fluid responsiveness. And the way you do that, and this comes from that very lovely paper, although quite comprehensive, but it contains a lot of very good information by Jan Bakker and colleagues. In all patients, you can use this method. So regardless of whether they're spontaneously breathing or on mechanical ventilation, you can always look at the left ventricular size. Looking at the visual assessment, you may also measure the left ventricular end diastolic, diastolic area. So a small hyperdynamic left ventricle suggests hypovolemia, whereas if you're looking at a ventricle that is dilated, this suggests either hypervolemia or increased filling pressures, and you would not give this patient more fluids. So all patients, you can use this method. In all patients, when you're more familiar with echocardiography, you may use your Doppler profiles as well. So this is the pulse wave Doppler profile. At the left ventricular outflow tract, you would measure the velocity time integral, and a variation coupled to a passive leg raising test. So you wouldn't just put your probe on and measure the VTI. You need to couple it to a maneuver such as passive leg raising. And passive leg raising is the only maneuver that works in both spontaneously breathing and mechanically ventilated patients, because it does not rely on heart-lung interactions. So you would measure your VTI before and after the passive leg raising maneuver, and a change of more than 12% indicates fluid responsiveness. And of course, if there is no change, you would not give the patient any fluids, because this patient is not going to respond by an increase in cardiac output. Importantly, however, the lowest significant change that can be detected by echocardiography is 11%. So this 11% is very close to the positive cutoff that is indicated by a change in VTI using PLR. So there's a significant gray zone there. So in patients with mechanical ventilation, here you may use heart-lung interactions to test for fluid responsiveness, because the cyclic changes in intrathoracic pressure induced by mechanical ventilation will have a bearing on cardiac preload and afterload. And what you would expect to see here is what you would expect to see here is significant respiratory variations to the peak aortic velocity. So these dots right at the peak of that velocity, or you may, of course, trace a velocity time integral that's a little bit harder to do. So a significant respiratory variation would be something more than, say, 10 to 15%. And of course, if it doesn't vary, you would not give the patient any fluid. So this is in mechanically ventilated patients, full mechanical ventilation with no spontaneous breaths. The moment you have a patient with a spontaneous breath, you cannot use heart-lung interactions, and you will need to use your passive leg raising test. So in mechanically ventilated patients, again, you can look at other parameters. For those of you using a transesophageal probe, have a look at your superior vena cava, and respiratory variations of more than 21% speak for fluid responsiveness. And for those of us who do not have a transesophageal probe, you may look at the IVC diameter, a large respiratory variation. Again, in mechanically ventilated patients with no spontaneous breaths, a large variation would indicate fluid responsiveness. Now, what about spontaneously breathing patients? Well, you could use the IVC diameter and a very small inferior vena cava. So a vena cava that is less than 12 or 13 millimeters, this is very small, with a total collapse will tell you that the patient is hypovolemic and probably needs fluids. Whereas a patient that has an IVC diameter of 20 or more that doesn't collapse with respiration does not need fluids. And for us sitting here before coffee or even after coffee, this is what we look like. We would be fluid responsive, but that does not mean that we need fluids. So inferior vena cava distensibility is the method that is most often quoted to me when I ask my residents and my colleagues, what method do you use for assessing fluid responsiveness? So I just want to, if there is one take-home message from this lecture, I want to impinge on you that IVC distensibility has a very poor predictive value for fluid responsiveness with an area under the curve of 0.65. It does not work very well, and in fact, it's not much better than the delta pulse pressure. So IVC distensibility, you may use it as some sort of a screening tool, but as Sheila mentioned before, you need to use a variety of tests, and it's probably not the best tool to use in terms of echocardiography, and there you would probably rely on the superior vena cava variation or the delta aortic velocity. So, in the stabilization and de-escalation phases, echocardiography may be useful also. Here you would want to use it to assess the adequacy of the treatment that you have already instituted in your patients, and you would also want to use it to assess whether or not the patient is fluid overloaded. And I'll tell you how. Lung ultrasound, easy to do, easy to learn, and acute pulmonary edema is diagnosed when you have a thin pleural line and a large number of irregular B lines. They may be separated or they may coalesce. You might see a total white lung. And in terms of weaning-induced pulmonary edema, when you put your patients on a spontaneous breathing trial, and you do a lung ultrasound before and after the trial, an increase in B lines of more than 6 indicates it's highly predictive for a patient that will develop weaning-induced pulmonary edema. What else can we do? We could do the VExUS. This is quite popular now. I'm not 100% sure how we apply it in intensive care patients. The original study by Boben Sogny was done in patients post-cardiac surgery, so these are likely to be patients with cardiopathies and increased filling pressures, and a VExUS-C profile was defined as patients with an inferior vena cava that was dilated more than 2 centimeters with venous Dopplers that were abnormal, so either hepatic portal or renal vein Dopplers. So it did predict acute kidney injury in this particular group of patients. However, in general ICU patients, there is a very low prevalence of venous congestion. So that VExUS profile that was described in post-cardiac surgery patients doesn't occur very commonly in general ICU patients. And there is no association with acute kidney injury and mortality. And that is not saying that VExUS, or venous congestion rather, is not useful. I'm sure it's useful. We need to learn how to use these ultrasound techniques. And I'm sure there will be more publications coming in the future. So, fluids, as much as necessary, but as little as possible, and echocardiography can certainly be used, and not just echocardiography, but ultrasonography can be used in all those 4 stages: salvage, optimization, stabilization, and de-escalation, but of course with different focuses and different goals. Thank you very much.
Thank you very much, Dr. Xu. Is there any question in the audience? I have a question. During the stabilization phase, how often do you recommend to perform echography to assess the fluid responsiveness for our patient? Because sometimes we have 3, 4, 5 patients on the stabilization phase in our ICU, and we have no time.
That is an excellent question, and this is probably one of the most compelling reasons for not using echocardiography as a monitor. However, for those of us that are echo nuts, and I don't have one of these, we have an echo ultrasound probe in our pockets. You know, there are lots of these very good portable ultrasound probes, and it doesn't take long. It takes, 3 minutes to do a fluid responsiveness test. So, and the thing with echocardiography as well is you don't need a cardiac output monitor, and not every patient has a cardiac output monitor. And I'm talking also about low and or resource poor settings. We also have a lot of patients in a perioperative care ward that don't have cardiac output monitors, step-down units. Every time you're thinking about giving fluids in the stabilization phase, you should be doing an ultrasound. And if you can't do that, then you need to be thinking of, you can't use PPV because patients are spontaneously breathing. So I think you're quite more or less stuck. But I do agree with you, it takes time.
Thank you very much.
Thank you for this excellent talk. Can you comment on the tidal volume we should use to have enough reliability with those echo-based indices?
Yeah. So for heart-lung interactions, there is a huge gray zone. So the larger the tidal volume, the bigger the respiratory changes in intrathoracic pressure. So usually we say you're more or less safe if the tidal volume is more than 8. If it's less than 8, the respiratory variations still work, but the gray zone becomes larger. Now, obviously, in all of our patients that are ventilated with low tidal volumes, if the fluid responsiveness test is negative, then you can't exclude that the patient is fluid responsive. So you would need to confirm that with another method. Or, and this hasn't been investigated yet, and it should be for those of you who are interested in doing research, turn up your tidal volume to 8, maybe from 4 to 8 or 6 to 8 milliliters per kilo. Put the ultrasound probe on, and perhaps with the VTI or aortic Vmax method, it may be more sensitive.
Then thanks a lot, and congratulations again. And our next speaker, I'm very pleased to introduce, is going to be Professor Paul Mayo from the United States. His talk is entitled Venous Congestion, Volume Intolerance, and the VExUS score.
I made the error of proposing this subject when the call went out, hey, do you have some topics? And when I started thinking about it, I said I shouldn't have proposed it because there's a lot of ambiguity to this discussion. And I think all of us who know about the VExUS score have this sense of ambivalence about it. Like, we'll use it, it's fun to say, you know, like, let's do a VExUS score. But it's vexing. So I may finish the talk having confused you, because I'm confused. Let's see what happens. The pragmatic definition for those of us, and I still live in the trenches in the ICU, a simple pragmatic definition for fluid intolerance is that further fluid resuscitation will hurt your patient. And the possible mechanisms are obviously the accumulation of peripheral edema, ill effect on RV-LV function, effect of pleural accumulation, acidic fluid, effect on chest wall compliance, effect on wound healing, upper airway resistance increases when the patient becomes very edematous, effect on lung function. It goes on, and the possibility that excess fluid accumulation will cause venous congestion, which in turn may cause organ dysfunction. The venous congestion cascade is sort of the hypothesis is that organ perfusion pressure is a critical value for maintenance of organ function. I think most of us would accept that as a general concept. A very useful model is one that all of you who take care of neuroinjured patients are aware of, that the skull being a rigid chamber, the cerebral perfusion pressure is critically related on the mean arterial pressure or systolic pressure and the intracranial pressure. And if the CVP is elevated, it will inhibit or reduce organ perfusion pressure. And it turns out, we all know that, you know, put the patient at 30 degrees, don't let them cough too much, and keep the CVP low and balance it with the blood pressure, control ICP if they're critically ill with usual measures. But it turns out that many of the visceral organs are subject to the same problem. For example, the kidney is surrounded not by the skull, obviously, but is surrounded by a rather rigid capsule. The liver as well. The gut is contained within the abdominal wall, which has compliance characteristics, and if pressure goes up within that compartment, the compliance of the chest, of the abdominal wall goes down. So we need to keep that in mind. So at a very simple with simple physiologic reasoning, what are the determinants of organ perfusion pressure? And one of the things that I think it's easy to forget is that we focus on the mean arterial pressure in the aorta. It's easy to measure, right? But we need to remember that the further down the arterial tree we go, the lower the final arteriolar pressure actually is. And you can see here that the mean arterial pressure in this patient is quite reasonable, but if you go down to the precapillary arterial pressure, that's quite a bit lower, probably on the order of 30 millimeters of mercury, even lower. And that drives blood through the capillary bed. And the gradient then required to drive blood through the capillary bed of our vital organs relates also to intra-organ pressure. And finally, there's what we would term a venous egress pressure, which resists perfusion of the organ. And we can call it, for purposes of this discussion, as the mean systemic filling pressure. Some people say it's called the mean systemic pressure. That's this hidden, mysterious pressure that's in the venous capacitance compartment immediately past the capillary bed. So you can see there are several major determinants here. And this results in what I would call, in some patients, a perfect storm. if you have an elevation of mean systemic filling pressure, that in itself reduces organ perfusion. And if you have increase of intra-organ pressure, that increases. And the typical feature of something like sepsis is an increase in vascular permeability, which if it's combined with elevation of mean systemic filling pressure, results in the accumulation of intra-organ edema and therefore pressure, because the organ cannot swell due to the capsule that surrounds it. And the presence of venous congestion, therefore, indicates a volume intolerant state. This was first observed back in 1894 when the investigator occluded venous outflow from a kidney, it's an animal model, and showed that urine output went down. It's been well described as a worrisome phenomena, venous congestion, in the cardiology literature going back to the 1990s. So we all know that the Montreal group, a couple of years ago, they took a look at Doppler velocity patterns in the hepatic vein, portal vein, renal vein, and they did a whole rather complex statistical analysis, and they came up with a score that they felt defined the presence of venous congestion. That was their opinion, and it was associated with acute kidney injury, if it was high, the score. And the most recent literature, there are 3 abstracts out that indicate that it's also associated with mortality in patients with sepsis. If you measure the VExUS score in patients in the emergency department, and it's high, they have septic shock, their final outcome is worse than patients who have a normal VExUS score. So we all know, Dr. Chu showed us the basic patterns. They felt that the VExUS-C pattern and was the one that was most meaningful, or they thought, or they posit that reflects venous congestion with all of its ill effects. Now, to keep you up to date, there are a lot of modifications that are going on. The VExUS score, and I know the Canadian group, they're a great group of people, very good humored, sort of funny, and they say that they put this out in sort of a small journal, and they were astonished when there was such intense interest in it, and they said, that's because we gave it a good name. That's their attitude. And in more modern practice over the last couple of years, there's generally, anecdotally, opinion that renal vein analysis is hard to do. The image quality is generally rather suspect. And I think most groups are moving away from laboring to try to get that. So keep that in mind. Hepatic venous inflow is quite easy to obtain in portal vein patterns, but there's now sort of the observation, supported by the Canadians, that you really need to have an EKG tracing going to analyze hepatic venous inflow. We don't have time to go into that in detail, but just keep that in mind. Whereas portal venous patterns, boy, when you get a good tracing, you can make a conclusion. You can get an actual score from that. Okay, now, also in their original analysis, you had to have a IVC greater than 2 centimeters. That makes no sense to make an arbitrary, absolute 20 millimeter. If it's 1.95, you can't do a VExUS score. No, that doesn't make sense. So a little bit of clinical judgment needs to be used there. And now the group is proposing a much simpler test to define venous congestion, which is femoral vein color Doppler. I give you 2 interesting, still anecdotal descriptions of this technique. And the great thing about this is it's really easy to do, and you can do it with an ultra-portable device. It doesn't have Doppler, but all the small ones have color. So keep that in mind as sort of a slow evolution away from the formal VExUS score in everybody, all right? What are the problems with this score? Well, these are cardiac surgery patients, very well-defined population, and the tracings that the Montrealians give us are perfect. Those aren't the ones we in my group get at the bedside, and I think that's because these patients were laid out totally passive on the vent or something, and they got these perfect tracings. And is this transferable general ICU population? And the greatest challenge we find is when you have respiratophasic variation in the dyspneic patient, the signal comes in and out of plane for obvious reasons, right? And you can't tell that dyspneic patient, stop breathing for 30 seconds so I can get a good tracing. That's not going to work. So the sicker the person is, if they're breathing spontaneously, the more difficult it is to get a really good quality tracing. The other thing is that patients who are obese, very heavily muscled, et cetera, they're difficult. We find TEE is quite useful. You get very good quality images for VExUS scoring off of TEE. I think the acute injury and the more recent mortality data is very impressive, but we have no studies that report what happens if you intervene. If you intervene in an attempt to reduce venous congestion, it's simply unknown. And the other thing is, does elevation of VExUS score actually indicate venous congestion, or is this still speculative? But really, what bothers me, all of you, is it's a great thing to do, gives you a score, but what are you going to do about it? And there's a lot of logic you could use to do something, but what you're doing hasn't yet been, quote unquote, been proven to alter outcome. So I'm over in New York. When patients come to my unit, they've gotten liters and liters of stuff from the house staff, from the ED, just pouring the fluid in. It's just, we look upstairs in my ICU to try to de-resuscitate as much as we can, all right? It's a New York City problem, a holdover from those lethal sepsis guidelines of the early 2000s. 30, then 60. If that doesn't work, give another 30. No, we got another 60. That crazy stuff that I see. So we use VExUS score to justify removal of fluid. And the rationale there is this is a signal that indicates organ function is impaired by venous congestion. And therefore, we routinely use it to justify de-resuscitation without much, quote, evidence. Am I right? I'm not sure. And we'll turn to the great Dr. Tobin, who would propose, and I think this is almost a direct quote, I've heard him say this, that in the absence of, quote unquote, EBM at the bedside, the best approach is sound physiological reasoning. And therefore, the venous congestion and possibly the VExUS score would allow us or permit us to reason that it's right to do something about it. The next step, though, will be to compare VExUS score to direct measurement of the mean systemic filling pressure. And I invite you this afternoon to come to demo box, I think 1, where Dr. Monet and I will be demonstrating to actually how to measure this. And I noticed Dr. Pinsky in the front row, and he taught me how to do this. Thank you, Dr. Pinsky. Are there any questions?
Thanks a lot. Questions from the audience? Maybe I start with one. When we look at venous congestion, should we advise to put a continuous monitoring of CVP, maybe looking at the trend during a FLUID challenge or even the shape of the curve back to physiology?
Last year, Jean-Louis Teboul destroyed me at a pro-con, I remember. And I'm tending towards his thinking that, in fact, CVP, whether it's measured with ultrasonography or directly, is important for this issue that you raise. My understanding is that the CVP may be elevated without the presence of venous congestion detected by VExUS scoring. But if it's elevated, the clinician best proceed with further assessment to see if there is venous congestion. So it's a marker of risk, there's no doubt about that. Okay, a marker, but it's not diagnostic of venous congestion. Dr. Pinsky, would you agree, because I have to be careful here, Dr. Pinsky, what is the value of the central venous pressure in assessing the risk of venous congestion? Could we give Dr. Pinsky a microphone?
Please.
Yeah.
It's coming.
See, this is good. My strategy, I don't know how to answer the question, so I get Dr. Pinsky to answer it. All right.
Hello. I'm going to give the last lecture in this session anyway. By definition, the mean systemic pressure has to be higher than central venous pressure, or there's no pressure gradient for blood flow. Period.
Yeah.
Except, thus, if you have a very high mean systemic pressure, 20, 24, you must have venous congestion.
Yeah.
However, other than that, if it's 10 to 12, it doesn't mean that you have venous congestion, but you may. Mm-hmm. If it's your CVP right now, everyone here is the same, and if they add all of them up, it's the same number, 0. A normal CVP is 0. It's about 1 or 2 if you lie flat, but that's it. An elevated CVP is bad, and with regards to fluid, if you're giving fluids and the CVP starts to rise, it means you have some degree of RV dysfunction, and you probably should slow down or stop it. Okay. Does that help? Good.
Yes, thank you. I think we're in agreement. Okay. Any other questions here? Thank you, Dr. Pinsky. Any other questions? Okay, good. That's it? All right, thank you.
Thank you very much. Excellent talk. So the next speaker is Jan Bakker from Netherlands. The talk is venous congestion can be present in fluid responsive patients. Thank you very much.
Thank you for the introduction. Paul, when I think about fluid resuscitation in New York City, it always reminds me of Will Shoemaker. Fluid intolerance doesn't exist. Fill him up to his eyeballs. Fluid responsiveness and venous congestion. These are my possible conflicts of interest, not related to this presentation. As I said, where do we come from when we think about fluid resuscitation and limits of fluid resuscitation? Yeah, it was Will Shoemaker. If you ask Dr. Shoemaker, what should we do? He said, fill him up to his eyeballs. Later on, continued by Dennis Edwards, who said, keep them dry and watch them die. And Dennis was a great proponent of giving lots of fluids. And then, of course, also already criticized by Paul, the surviving, the sepsis fluids, a weird concept developed from a very interesting study by Emmanuel Rivers, where he targeted optimizing blood flow by using this CVP range to guide fluid resuscitation, and it ultimately resulted in 30 ml per kilo when you have sepsis. So when should you use fluids? Well, you should use fluids when you think that fluids will increase cardiac output, and that this increase in cardiac output will partially or completely restore tissue perfusion if tissue perfusion is a problem. That's the only reason you should give fluids apart from dehydration and stuff like that. But this is in the critical care context. So if you think that won't happen, then don't give fluids. We never should resuscitate patients to a state where they are fluid unresponsive. That doesn't make any sense. It's not about unresponsiveness. You can use, let's say, the limit of fluid resuscitation, making your patient fluid unresponsive. If you have continuous improvements in tissue perfusion, then the fluid unresponsive state is, okay, stop. You now have to use something else. And if you look at fluid unresponsiveness, this is part from results from the Andromeda 1 study, where getting to fluid unresponsive state was at, let's say, the limit of fluid resuscitation if you wanted to decrease lactate levels or improve capillary refill time. And as you can see at baseline, as already alluded by Paul, a majority of patients was already, or not the majority, but a large part of the patient was not fluid responsive anymore. About 50–60% was fluid responsive, and if you look at the duration of the study, Andromeda 1 was 8 hours, Andromeda 2 is 6 hours. You see that the number of patients that remain fluid responsive is very low after the first 2 resuscitation efforts. We did resuscitation every 2 hours. And so at the end of the protocol, only 3% was still fluid responsive. And of these fluid unresponsive patients, a very small proportion became fluid responsive afterwards. And so fluid responsiveness makes sense, but not as a goal of therapy. This is a study done in 2015 where they looked at the VExUS score and the occurrence of acute kidney injury. And they found in their analysis of over 1,000 patients that 17% of the patients presented with venous congestion. And when you use the VExUS score, it's a score of 2 or higher. And they found that venous congestion was associated with increased incidence of AKI. That doesn't mean if you're venously congested, you will thus always develop AKI, but it's definitely a risk factor for developing AKI. And what we did with one of my PhD students, Michel van Genderen, is, okay, if our goal is optimizing perfusion, why can't we stop giving fluids if we have what we think is optimized perfusion? And in this study, very small study, only 30 patients, we used peripheral perfusion as the endpoint of resuscitation. And our question was, if lactate doesn't change, if the blood pressure is not, let's say, higher than 65, but we have normal peripheral perfusion, is it safe to stop resuscitating? Because that's an interesting question. If you want to stop resuscitating on a given endpoint, is it safe? And so that's what we did. In every patient that normalized their peripheral perfusion, we stopped resuscitating. Whatever the lactate or whatever the blood pressure was, as long as it was more than 65. And we found that it seemed in these 30 patients, randomized, so that's 15, not a huge number of patients, the signal was that this seems to be safe. If you stop resuscitating when your peripheral perfusion is normal, you have a decrease in SOFA score during the first 3 days, whereas in the control group, nothing changed. So at least there is no signal that this is very bad. And then we looked at, that's already last year, we looked at the coexistence of fluid responsiveness and venous congestion. Now, if you follow Dr. Shoemaker and fill him up to his eyeballs, I mean, you can fill everyone up. The question of fluid unresponsiveness, of fluid tolerance is, of course, should you give fluids to a patient with venous congestion? That's the question. And what causes or what is related to development of venous congestion? Well, we found, as already discussed somewhat earlier in the session, CVP is an important indicator of fluid unresponsiveness, and it's not fluid balance. So it's not, yeah, we already have a 2-liter positive fluid balance, so let's not give any more. That doesn't make any sense because there is no evidence looking at fluid balance and venous congestion, but CVP definitely. And Dr. Pinsky already gave the reasoning. Now, in this study, we also looked at if you're fluid responsive and you meet VExUS scoring venous congestion, how many of those patients are there? And we found that it's about 21% of fluid unresponsive patients have venous congestion. So VExUS score 2 or 3, orange and red. If you look at fluid responsive patients, so if you give fluids, they increase their cardiac output, it's 15%. So that's not a small number of patients that respond to fluids with an increase in cardiac output and still have a signal that there is venous congestion. Whether not doing anything, giving furosemide, decreasing the volume, makes any sense for the outcome of these patients, we don't know. This is just observational data, but common sense would say, well, if I have a signal of venous congestion and the patient is fluid responsive, maybe use something else to increase blood flow than fluids. And so in this journal, they came to they discussed how to evaluate fluid responsiveness and assessment of fluid tolerance. And the assessment of fluid tolerance should precede the assessment of fluid responsiveness. So basically what they say is do a VExUS score first and then do a passive leg raising, arguing that if the VExUS score is already increased, you don't have to do passive leg raising because you would not give fluids. Eduardo Cotan, another PhD student of mine, more extensively made a graph of this, so how to do this in clinical practice. And so he said, if you are in fluid resuscitation, then assessment of fluid responsiveness comes after your assessment of fluid tolerance. And so this makes life, to be honest, a lot more complex. It's much more complex to do and VExUS scoring and passive leg raising and then ultimately decide on whether you should give fluids or do something else. But at the end of the day, it makes more sense. Does this improve outcome? We don't know. We don't have any studies yet to, let's say, evaluate this concept. So, in conclusion, remember, fluid unresponsiveness is a pathological state. There is no physiology in fluid unresponsiveness, just like a high CVP is a pathological state. As Dr. Pinsky said, the CVP of all of us is 0. If there is anyone in the room with a CVP of 10, prepare yourself because you're in trouble. And if you're not in trouble today, you will be in trouble soon. And so fluid unresponsiveness should never be a goal of your therapy, unless. And so being fluid responsive doesn't mean the patient is hypovolemic. I have to admit I contributed to this myself in the lactate study. We said if you're fluid unresponsive, we mark this as hypovolemic, and you should give fluids to decrease lactate. That was a misnomer. That's not the way it should be done. The goal of fluid resuscitation is to improve global blood flow. And if you are lucky, regional blood flow as well, but without paying a price of congestion, because congestion will limit tissue perfusion in and of itself. It is not about the amount of fluids, as even limited amounts of fluids can result in venous congestion. As you saw in the slide, in the study we did, just half of the patients was already fluid unresponsive when they came to the ICU. They were already unresponsive with the limited fluids they got in the emergency room. There is no clear evidence, to be honest, that the fluid responsive state is associated with outcomes. where signals of venous congestion are associated with morbidity and mortality. There is also no real evidence that preventing this will improve outcome, but I mean, common sense would probably result in that's not what we want. When the ultimate goal is to improve tissue perfusion, a signal of congestion should at least make you rethink about giving fluids or doing something else. Thank you very much.
Thank you very much for this very impressive presentation. Is there any question in the audience? I will start. In those patients with fluid responsiveness and venous congestion, 25% in an observational you show us. I don't know, is it a new infections of our patients in this situation? Is it an argument for new infections? Or is it a fluid leakage that continue from the first sepsis? How these patients could be interpreted?
Well, the venous congestion signal is a venous signal following the organ, so at the entry of the organ. It doesn't assess whether there's edema in the organ or either edema in the tissues. It's just a venous signal of pressure or pressure related, because you measure diameters, you don't measure pressure. And so it's a signal that there is increased pressure, probably related to the diameters, related to the fluid resuscitation you did before, or right ventricular dysfunction, as Dr. Pinsky said. If you have edema at the end of, after your organ, so your venous outflow, that means systemic filling pressure result. And so if you have high CVP, you always have a higher mean systemic filling pressure. And so the challenge of this fluid and the challenge of this pressure determines the, let's say, creation of edema at the end of the day. So we're not actually assessing edema, but it's a risk for edema. And as Paul clearly said, VExUS score is not over and done. It's a very, let's say, crude assessment of possible venous congestion. And I think we still have to do a lot more work than we have done up until now. Venous VExUS score is very young, to be honest.
There is a question here, if I can have a microphone, please.
Thank you very much for your talk. I enjoyed it a lot. My question is about, in presence of hypoproteinemia, malnutrition, then how you define venous congestion?
The venous, as I said, the venous congestion signal has nothing to do with, let's say, the ability of the organ to maintain fluid, or the system to maintain fluids inside the system. So if you have capillary leak, the fluid will disappear. That's, of course, a confounder. That's maybe the reason why fluid unresponsive patients ultimately become fluid responsive again, because the fluid disappears due to vascular leak. But the VExUS score in and of itself does not assess.
And the related question, imagine you have a patient with clear venous congestion, a lot of edema, and severe hypoalbuminemia. Would you consider to give albumin or not?
Always. I always got an email from, when I worked in New York, I always got an email from pharmacy that albumin was not indicated. And I always said, show me the evidence, and stop sending me emails. But yeah, absolutely. Absolutely.
Another question from the room, maybe? No? Then we are going to continue. Thanks again. I'm now very happy to introduce our next speaker, who is Jean-Louis Teboul from Paris, France. And he's going to discuss a key question, the question of fluid resuscitation in the presence of right ventricular dysfunction.
Thank you very much, and good morning, everyone. So it's difficult to talk after Jan, but I will try to Okay, you go to the poster session where I was chairing just before. Okay, so my conflicts of interest, but I have no conflicts of interest for this presentation, to be honest. So first, I would like to remind you the major causes of acute right ventricular dysfunction in critical patients: sepsis-induced myocardial dysfunction, acute pulmonary embolism, RV dysfunction due to ARDS, and this kind of patients could be due to hypoxic vasoconstriction, to mediators-related vasoconstriction, to perivascular edema, microthrombi in pulmonary vessels, and microvascular remodeling. So all these mechanisms can create some pulmonary hypertension and hence RV dysfunction. But there is another one, which is interesting to look at, is the deleterious effects of mechanical ventilation plus PEEP. If the first one, sepsis-induced myocardial dysfunction, in fact, is an acute decrease in contractility, and the other ones, an acute increase in the pulmonary vascular resistance. But I like also to subdivide this in another way. The first three ones are structural causes of RV dysfunction, and the last one, a functional cause of RV dysfunction. And you will see what I mean in my next slides. What about fluid administration in such cases? First, let's look at fluid administration in case of structural causes of RV dysfunction. You know this Frank-Starling curve, and you know that if the right ventricle is dilated, fluid infusion will result in no increase in RV stroke volume, of course, but we also have to consider the diastolic function curve, the volume on the x-axis, and the endoscopic pressure on the y-axis. This is like this, and if you give fluid in a ventricle which is not dilated, you have a very small increase in the pressure. But if your ventricle, for example, the right ventricle, is already dilated, the same amount of fluid will result in a huge increase in the pressure. Means a huge increase in the right ventricular endoscopic pressure. Means a huge increase in central venous pressure, which is the back pressure for venous return. And if we remember the Guyton model, we know that if we increase the right atrial pressure, or the CVP, we can have a decrease in cardiac output according to the Guyton model. But Guyton also said that venous return and cardiac output are equal at steady state. So we have to combine the venous return curve and the Frank-Starling curve. And the optimal situation is this crossing point, optimal right atrial pressure, optimal CVP for an optimal cardiac output. Now, if we are in the case of RV dysfunction, we are in the case of RV preload and responsiveness with a marked increase in CVP due to the diastolic dysfunction. So if you start from this point, you give fluid, you shift the venous return curve to the right with an increase in the mean systemic pressure, okay? So there is no change in the Frank-Starling curve, but there is a huge increase in the CVP for the reasons I told you. Therefore, with no change in the shape of the Frank-Starling curve, you have a decrease in cardiac output because there is a movement of the equilibrium point to the right and down, decrease in cardiac output. So, if, in spite of the increase in the mean systemic pressure induced by fluid infusion, there is a risk of decrease in venous return pressure gradient and therefore a risk of decrease in cardiac output. If adaptive mechanism fail to increase the mean systemic pressure, sometimes it can increase the mean systemic pressure. Finally, the decrease in cardiac output is not so high. But you remember that CVP also is a back pressure for the perfusion of important organs like the kidney, for example. And therefore, if there is an increase in CVP due to fluid infusion, you have also an increase in the organ venous pressure, which can create a reduction in the organ perfusion pressure, MAP minus this pressure, but also you could have some interstitial organ edema due to this venous congestion at the capillary side or at the venular side of the capillaries. And therefore, you can create some organ dysfunction. So I summarize. If the right ventricle is dilated, fluid infusion can increase the right ventricular endosystolic pressure, CVP, and with a risk of organ dysfunction. But in addition to this, sometimes the RV is dilated, and due to the ventricular interdependence phenomenon, this can reduce the filling of the left ventricle, and this can reduce the stroke volume of the left ventricle. And again, you could have a risk of decrease in cardiac output due to this additional phenomenon. So you understand that at the end of the day, when you have a structural cause of RV dysfunction, please don't give fluids, because you can decrease cardiac output and you can create some organ dysfunction. But more interesting, I think, are the effects of mechanical ventilation plus PEEP. What about fluid administration in such cases? But just go back to basic physiology. You know that in the lung microvessels, we have in fact two categories of microvessels. We have the intra-alveolar vessels and the extra-alveolar vessels. When you increase lung volume, you have a compression of the intra-alveolar vessels and a dilation of the extra-alveolar vessels due to lung stretching. So lung volume decreases the resistance of the extra-alveolar vessels. And if we represent this on this graph, pulmonary vascular resistance and lung volume on the x-axis, there is an exponential decrease in the resistance of these extra-alveolar vessels. But at the same time, you have a compression of the intra-alveolar vessels, and therefore the transpulmonary pressure is able to increase the resistance of the intra-alveolar vessels. So this is explained by the lung, the west lung zones, you know, the zone 3, 2, and 1, due to the hydrostatic gradient from the bottom to the top of the lung. In the zone 3, all the intravascular pressures are higher than the alveolar pressure due to the hydrostatic gradient. In the zone 2, the alveolar pressure is higher than the venous pressure. Zone 1, alveolar pressure is higher, are all the pressures. But the pulmonary vascular resistance increased from the bottom to the top of the lung. So we have this kind of representation, graphical representation, an exponential increase in the resistance of the intra-alveolar vessels. As you know, the resulting effect is a U-shaped curve with a nadir of the curve as a more or less at the R-C level. So now, if you ventilate a patient like this, you start from the R-C, almost by definition. If you give a low tidal volume, there is only a small increase in the pulmonary vascular resistance. Of course, if by mistake you increase the tidal volume, you have a huge increase in the pulmonary vascular resistance. But now we use less. What about PEEP application? If you give PEEP, it is because your end expiratory lung volume is too small and you want to recruit some volume. So you start from this part of the curve. You start from here. And if PEEP is effective to recruit lung units and increases the end-expected lung volume toward the R4C, you have just a decrease in PVR, not an increase in PVR, but a decrease in PVR. Of course, if you apply a tidal volume after this, which is normal, you have a small increase in PVR. So if PEEP is recruiting lung volume, you should not have an increase in PVR. This is what we demonstrated in this study with Simone Capio-Morlino, Xavier Monet, and others in Bicêtre Hospital. In patients who are defined as high recruiters with PEEP, we have no change in PVR when we increase the level of PEEP. But if PEEP does not recruit, if PEEP overdistends the lung, in this case, you have an increase in PVR with PEEP, and then a further increase in the PVR with tidal volume. In this situation, you have some risk of RV dysfunction. And this is what we demonstrated in this study again. We also looked at low PEEP recruiters. As you can see, PVR increased. We also looked at another parameter, which is the TAPSE to the systolic pulmonary artery pressure, which is a marker of the RV pulmonary artery coupling. In this case, in case of low recruiters, we have an uncoupling with PEEP and RV dysfunction. So the hemodynamic effects of mechanical ventilation plus PEEP are variable depending on its capacity of recruiting or overdistending lungs, also its capacity of improving arterial oxygenation, because to reduce the hypoxic vasoconstriction, the degree of airway pressure transmission, and volume status. And volume status is very important because this is a forgotten factor. And the question is, does hypovolemia improve or worsen RV function during PEEP ventilation? In fact, hypovolemia should favor the extent of zone 2 by reducing the intravascular pressures. Because if you have hypovolemia, you have a decrease in the central blood volume, a decrease in the pressures inside, a decrease in the venous pressure in the lungs. And therefore, you have an extent of the zone 2 conditions, and you have an increase in the pulmonary vascular resistance. So hypovolemia can worsen RV dysfunction in this kind of situations, mechanical ventilation plus PEEP. And you shift this curve, and you have a higher increase in PVR in case of extension of zone 2 conditions due to hypovolemia. And this is what we addressed in this study with Émilie Fougère, Xavier Monet, and others years ago. We looked at patients with ARDS and low tidal volume. At the beginning, we gave only 5 centiliters of water of PEEP. We increased PEEP, keeping the same tidal volume until a plateau pressure less than 30 centiliters of water. And the average PEEP was 13 centiliters of water. And we perform a passive leg raising, not to predict fluid responsiveness, but just to simulate a volume challenge. And we assess hemodynamics using the Swan-Ganz catheter and using echocardiography. What we found, when we increased PEEP, we had a decrease in cardiac index. It's not new, but also we have an increase in PVR, pulmonary vascular resistance, and also an increase in the RV, LV, and the ventricular ratio, which is a marker of the size of the RV, which increases with PEEP. Afterload increase with PEEP. When we perform a volume challenge, passive leg raising, we reversed all these anomalies. We increase cardiac index, decrease PVR, and also the RV, LV, and ventricular ratio return to baseline values. Therefore, with volume, we decreased RV afterload. And this is illustrated by this phenomenon, because when we gave volume, finally, we decrease the extension of zone 2, and we have more zone 3 conditions, and finally, PVR decrease. So correction of hypovolemia by decreasing the extent of zone 2 attenuates the deleterious impact of mechanical ventilation plus PEEP on RV function. And we return to this curve. So my conclusion, in critical patients, RV dilation may occur due to structural causes, and in this case, fluid infusion cannot increase cardiac output. It can even decrease cardiac output, and also can create some organ dysfunction due to the decreased cardiac output and also due to the increased CVP. But in patients receiving mechanical ventilation plus PEEP, RV dilation may also occur due to mechanical ventilation itself, due to the high transpulmonary pressure, which increases PVR due to the extension of zone 2 conditions. In this case, by increasing pulmonary venous pressure, fluid infusion can restore zone 3 conditions and thus can decrease pulmonary vascular resistance, can decrease RV size, and can increase cardiac output. In cases of any doubt, PLR can be helpful, especially in ARDS where structural and functional causes may coexist. Thank you very much for your attention.
Thanks a lot for this wonderful talk. Are there questions from the audience? Yes, we have one here. Can we have the microphone once again?
Excellent presentation, but I have a doubt about a patient who had been on ventilator with PEEP and RV dysfunction, and we are giving fluid because that can improve the outcome. And once that patient got extubated and still there is RV dysfunction, and in that situation, because this can happen, you have ventilated and patient got better and you have extubated, and then still RV dysfunction takes time to resolve if sepsis induced. In that situation, what will be our approach?
Now, my point, and the second part of my presentation was to draw attention to the fact. I don't say give fluids to ARDS patients. I would say that if you create some hypovolemia because you want to follow a dry attitude, you know this dry attitude in ARDS consisting in restricting fluid administration because we don't want to worsen pulmonary edema, this dry attitude is not reasonable. We need to see if you can finally restore some good RV function just by giving a little amount of fluid. This is the point of my presentation. Because sometimes people say, oh, there is RV dysfunction, don't give fluids. Yes, if the RV dysfunction is due to structural causes. If it is due to mechanical ventilation and PEEP, we have to be more careful and we have to perform PLR, etc., to be sure that maybe we can correct something without causing harm. This is the point of my presentation.
Another question from the room? Maybe I have one. You very nicely showed us that the impact of PEEP on right ventricular dysfunction depends on recruitability and on the fluid status. But what about proning?
What about?
Proning,
prone
yeah. Position.
That's a good question. Good question because I have the answer. So prone position is good for the right ventricular function. So if you have to prone ARDS patients for hypoxemic reasons, it's okay. But if the patient, in addition, has RV dysfunction, it could be an additional indication for proning the patient. And there are some papers, we performed 2 papers about this, showing a clear improvement on RV dysfunction when you prone the patient. So this is a treatment of RV dysfunction. You cannot 100% correct RV dysfunction, but you can improve a lot. In one of the studies, I remember, we observed a decrease in PVR by 40%. 40% just when we prone the patient. So this is a good treatment of RV dysfunction associated with ARDS.
Thank you very much, Dr. Teboul, for this excellent presentation. And it's a pleasure to introduce the last speaker, Michael R Pinsky from Pittsburgh, for a talk on the limitations of dynamic parameters to detect cardiovascular insufficiency. Thank you very much.
Thank you very much. I guess I'm batting cleanup in this program. It's a very interesting one. I'm sorry I wasn't here for all of it. I had to give 2 lectures and 2 other sessions. The process here is to talk about dynamic parameters, which is something that we've been working on for a while. These are my conflicts of interest. They have nothing to do with what I'm going to talk about. The reality is that we can't use static measures of preload to assess volume responsiveness. Neither CVP or its change or wedge pressure or its change relate to end-diastolic volumes or to stroke volumes. A reality is that preload does not equal preload responsiveness. I can have a big ventricle and be volume responsive. I can have a small ventricle and not be volume responsive. The most common form of heart failure today is heart failure with preserved ejection fraction. Give those people volume and they'll go into pulmonary edema. So all static measures don't work. But we knew this a long time ago. In the same lab where Starling did his studies in 1890, ANREP looked at it as well. And he discovered that there was a homometric control independent of changes in preload. This is a study at an isolated human heart being perfused with Krebs henselite solution in 1959. So it's a denervated heart. And what you can see is the stroke volume is shown here from the end systolic to the end diastolic. And all the investigators did was turn up the pump, increasing venous return. And bang, you get immediate increase in preload and an immediate increase in stroke volume. That is Starling's law of the heart. But watch, in this totally denervated heart with no change at all in venous return, the stroke volume remains elevated, but the end diastolic volume actually gets lower. That is an increase in contractility. That is the ANREP effect. And this is what happens in all of us in 1 or 2 minutes after starting exercise. It's the reason why when you feel terrible as you start jogging, you just don't worry about it, and 2 minutes later you're in the zone. No, you're not. The ANREP effect is taken over. And thus, because of that, the patients will never have a static measure show their volume responsiveness. Starling and ANREP, unfortunately, are processes that only last for about 2 hours. They're not meant for any more than that. Long term, we have hypertrophy or dilation, but we in the ICU live right here between those 2 points. So using heart-lung interactions for the last 50 years, I've been studying the effects of intrathoracic pressure on left ventricular function, and increases and decreases in intrathoracic pressure must alter venous return independent of the heart itself. And in 1984, I published this study in which I showed that if an intact animal model, as you have negative swings in pleural pressure associated with spontaneous breathing, CVP falls, decreasing the pressure gradient for venous return. And as you can see, CVP is 0 here, but it falls, and venous return increases, and right ventricular stroke volume goes up. On the opposite side, with positive pressure breathing, pleural pressure goes up because of the increase in lung volume, causing it to go up mechanically. This decreases CVP, and there is a dynamic change in preload. And the stroke volume goes down the right ventricle, as you can see. This is the basis for the functional measures of stroke volume and pulse pressure variation. Subsequently, with André Deneau, who is now quite famous for his work on VExUS scores when he was our fellow, we went into the operating room, and as you can see, the decrease in right ventricular stroke volume after 2 or 3 beats decreases left ventricular stroke volume. And thus, as we showed before, if you have 2 hearts, one that's good and one that's bad, and they're in positive pressure breathing, they will show the same degree of stroke volume variation if they're volume responsive. Eventually, the not-so-good heart won't be volume responsive. And as you saw from Jan Bakker, everyone eventually gets non-volume responsive if overloaded. We also showed in human beings that there is a very tight relationship between changes in stroke volume and changes in arterial pulse pressure. And that's really important because I can measure arterial pulse pressure in anyone with a radial arterial catheter in. I don't need any fancy devices. And so if I can look at pulse pressure variation, as we saw in this study in 1999 with Frédéric Macquart and Jean-Louis Teboul, he and I worked on this together, you can see that the classic example of positive pressure breathing, and this is ARDS patients with PEEP, you can see that you have a systolic pressure variation, that's pulsus paradoxus. But if you look at the stroke volume, it's going to be the diastolic to systolic. And if you look at the mean diastolic to systolic over about 4 or 5 beats, you get a change in pulse pressure, which we quantified, and the level of baseline pulse pressure variation that was present at a tidal volume of 8 mLs per kilogram, which altered venous return, accurately predicted the increase in cardiac output that was seen in these ARDS patients. And in this subsequent study, these are septic patients. And more importantly, as you gave fluid and the cardiac output went up, the degree of volume responsiveness goes down. And thus you can see the response to treatment by the decrease in pulse pressure variation without a need to measure cardiac output. Well, this can be done with pleth variability. You don't need an arterial catheter. You can use esophageal Doppler, and that's fine. But these factors were all predicated on the fact that positive pressure breathing changed intrathoracic pressure to an amount necessary to decrease venous return. It is a normal physiologic state. Everyone in this room, I hope, is volume responsive. Nobody in this room, I pray, is in shock. But if I gave any of you fluid, you would have an instantaneous increase in stroke volume. Over 2 minutes, you'd have no change in cardiac output. What would happen is you'd have an increase in urine output, because the determinant of cardiac output is not the blood you give in or the fluids, it's metabolic demand of the body. But to be able to use this measure, you have to have an increase in intrathoracic pressure causing a decrease in venous return. This is totally abrogated if you have spontaneous breaths, because pleural pressure falls, and I already showed you that if pleural pressure doesn't rise, you're not going to get a fall in venous return. So you have to have an adequate change in intrathoracic pressure, and the small tidal volume may not do it. If a small tidal volume does it, you're volume responsive, but if it doesn't, you still could be volume responsive. You also need to have a common heart rate, because simply atrial fibrillation alone will give you pulse pressure variation. And false negatives occur when you have an increase in intra-abdominal pressure, because as the intrathoracic pressure rises, if you have an increase in intra-abdominal pressure, this causes your mean systemic pressure to rise as well, and there's no change in the pressure gradient for venous return, even if you are volume responsive. And there is questionable performance of these things if you have right heart failure, but you have to have pretty bad right heart failure for this to be true. This was a study that was done by Xavier Monet and Jean-Louis Teboul in their group, and they simply looked at the effects of pulse pressure variation on a person who was fully adapted to the ventilator, and they compared it to what would happen with a patient with spontaneous breathing. Spontaneous breathing doesn't work. They then looked at the effects of 6 ml per kilogram tidal volume versus, this is Daniel Bakker, I'm sorry, from Jean-Louis Vincent's group. As you go up to a larger tidal volume, you get a better response. The dotted line was on low tidal volume. The solid red line is on high tidal volume. So you need to have a large enough tidal volume to be able to have a change in the pressure gradient for it to work. And Jean-Louis brought up the point that you should look at it as a false negative and false positives. So I will get a false negative if the pulse pressure from pulse pressure variation if I have a small tidal volume, but if I have a good pulse pressure variation and a small tidal volume, I'm still volume responsive. Okay? So Sheila N Myatra thought, why don't we just jigger the system and look? Why don't I go from a 6 ml per kilogram tidal volume up to 8? It's called a tidal volume challenge. I can do that for 10 breaths, then go back to 6, and it won't hurt anybody. And then look at the change in the pulse pressure variation. And when she did that, she said a 3.5% change in pulse pressure variation or 2.5% change in stroke volume accurately predicted volume responsiveness. And you can measure this in anyone. And you don't need a special catheter, just an arterial catheter, and look at the pulse pressure variation. So Daniel Bakker and I said that if you're breathing spontaneously, you either do volume challenge or passive leg raising. And the passive leg raising, as you know, gives about 300 mLs in a 70-kilogram man. And in our initial study with Xavier Monet, you can see that this is the example of volume passive leg raising. And you see from the moment that you raise the legs, it instantly goes up. And this is volume response. This was a spontaneously breathing person with atrial fibrillation. So it works in everyone. Based on that, we wrote a review article characterizing all of the things. This was in intensive care medicine about 5 years ago, showing all the different methods and whether they worked. Importantly, as Glenn Hernandez showed in the Andromeda study, as was shown to you earlier today by Jan Bakker, that most patients when they come in are volume responsive if they're in septic shock, but as you can see here at time 0, the non-responders exceeded the responders, and over a very short period of time, very few people were volume responsive. Volume responsive is a normal physiologic state. Being non-volume responsive has another term. It's called cor pulmonale. You don't want to push your patient into being non-volume responsive. In an ideal world, we would say a magic number of 12% pulse pressure variation above, give fluids. If it's below, don't. But that's not real. Patients have risks, and giving fluids will be dangerous. And so we should calibrate it based on their needs. And in that review paper with Manu Milbrandt, as you can see, we talked about the fact that there are risks of giving fluid even if you're volume responsive. So at the end of the day, you have to balance the benefits versus the risks. And venous hypertension is a terrible thing. The body has no defense for venous hypertension. It will cause acute kidney injury. Now, what does work when all these things are there? That's the relationship between pulse pressure variation and stroke volume variation, here shown in a curve in which you look at the ratio of the two of them. And if you have a big pulse pressure variation compared to the stroke volume variation, you're vasoconstricted. If you have a little pulse pressure variation compared to your stroke volume variation, you're vasodilated. And the magic number is 1. If you're less than 1 on pulse pressure variation over stroke volume variation, you're vasodilated. Can we use that? Yes. Let's assume you're volume responsive and you're hypotensive and you want to resuscitate the patient. Can I use dynamic parameters to look at it? Yes, because if your dynamic arterial elastance is low, giving fluid will increase cardiac output, but blood pressure won't go up and you'll develop organ dysfunction. And those patients that are shown on the green line, they need norepinephrine simultaneously with the fluids. And in fact, Ignacio Monge Garcia showed in septic shock patients who are volume responsive, the only thing that predicted the increase in blood pressure, the blood pressure responders, was a dynamic arterial elastance greater than 1. And Maurizio Sassoni then looked at post-op cardiac patients in the ICU, non-intubated, breathing spontaneously, and he found the exact same number. So Ganot et al. Said, if this is true, why don't I wean norepinephrine from patients who are coming out of surgery who need it just based on the fact that their dynamic elastance is greater than 1. So he instructed the nurses that you either wean them in one group using the standard protocol, or in the other group, if the dynamic elastance is greater than 1, You can cut the norepinephrine in half, and he was literally able to get the patients off pressors and out of the recovery room in half the time. So in conclusion, dynamic parameters of cardiovascular state do not define cardiovascular insufficiency. They are used to determine cardiovascular responsiveness. Functional parameters need to have an adequate driving pressure, but if you are not volume responsive, and it is real, this is an absolute indication not to give fluids. It allows personalization of fluids and vasopressors, especially if you also look at the ratio of pulse pressure variation to stroke volume variation. And these ventilator-induced parameters are limited, as I just showed, by arrhythmias, spontaneous breathing, low tidal volume, and high intra-abdominal pressure. Thank you for your attention.
Thank you very much, Dr. Pinsky, for your talk, for your excellent talk. You are the last speaker, and it will be the end of the session, but I would like to have your take-home message for the audience, for the non-experts in this question. We have seen a lot of tools, PPV, echo, CVP, ventilator parameters, and in our daily clinical practice, for example, for septic shock patients, should we use all these tools, or should you use one or two tools to monitor our patients?
There is no question that you should only use a tool that you're familiar with and are comfortable using. So if you know how to measure the change in cardiac output with passive leg raising, please use it. But if you don't know how to do a passive leg raising maneuver and you don't want to learn how to do it, then you can easily look at pulse pressure or stroke volume variation during ventilation and tidal volume challenge. However, you should have at least two of these, and I really think that the passive leg raising one is the best because that works in spontaneously breathing patients as well, and it's relatively easy to do. It's been done by cardiologists for a little over 200 years as a way of assessing if increases in blood flow alter cardiac sounds, mitral regurg, murmurs, etc., because they know it works. So this is not a new maneuver. This has been well established. And so I would recommend that if you know nothing else, you should learn how to assess dynamic changes in pulse pressure and cardiac output in response to passive leg raising, and also know at least one of the things to do during positive pressure breathing, such as pulse pressure variation and the tidal volume challenge, because it's safe and it's accurate.
Thank you very much for this message. Question? Yes, microphone.
It's coming.
Thank you very much for your talk. I like a lot, and the other talks. My question probably is a stupid question. Is nobody referred to the position, the body position of the patient? I understand that all the measurements and therapeutic challenges have to be done in supine or not, but be aware that we care our patients in semi-recumbent positions. Is, let's say, 45 degrees above the horizontal. How is going to modify the measurements and everything is a very basic question, but nobody referred to that.
Okay, thank you very much for that question. The answer is this has been studied. In prone positioning, the dynamic parameters work just fine. The exact same thresholds are the same. When you're at, we don't normally put a patient at 45 degrees, we put them at 30 degrees. And in 30 degrees, the pulse pressure and stroke volume variations are also the same, and the reason is that when you're at 30 degrees, you're in a circulatory steady state. And if you go up from supine to 30 degrees, you're going to get a decrease in cardiac output in anyone because it's a hydrostatic challenge. But once you're there, It's a steady state, and the dynamic challenges are just the same. And in the last few studies over the few years, every patient has been in 30 degrees, and they show the same response. Okay? But it has to be a steady state. So you don't put them in 30 degrees and instantly change the tidal volume, because you have to be in steady state. But if you're in steady state, the systems work, and they work in the prone position as well. Thank you for that question.
Another question over there. May we have the microphone?
Dr. Pinsky, you mentioned in passing the adverse effects of venous congestion, and some of the earlier talks dealt with the VExUS score. Could you give a summary of your thoughts about VExUS score, its relation to venous congestion? What should we do with the value in the absence of clear, outcome? Because we're all using it. Well, what do you think?
Okay. Well, thank you for that question, Paul. The VExUS score is a very new method of assessing venous congestion, and it is unclear at the present time if it's universally translated into increase in venous congestion in the tissues. It probably is for the kidney and the gut, because that's where you're measuring it. But it is unclear how bad that is. The one thing we know for a fact is that the body cannot defend against venous hypertension. It has no physiologic response because it's never seen it in its evolution. And for the same perfusion pressure, if the venous pressure is higher, the kidney and the gut and the liver and the brain, the encapsulated organs, and the gut is encapsulated in the intra-abdominal compartment, are all going to be failing. And in fact, in a large study of patients who had kidney transplants, they separated them into those who pre-transplant, the donor, had a CVP of 12 or less or 12 or more. In those where the CVP was 12 or more, they had dysfunction of the kidney for the first 30 minutes after reperfusion before they made urine, but they then recovered. Whereas the others started peeing as soon as they connected the artery and vein. Okay? So we know for a fact that capsulating the kidney causes a tamponade of the kidney, and if you simply cut away the kidney's capsule, it starts to pee again. Okay? But you're not going to do that in a patient. So the point is, we know that venous congestion is bad. We do not know the correlation at the moment between acute venous congestion and organ function. We do know chronic venous congestion and organ function is not that bad because the body adjusts to it. So in the acute situation, this is information we need to know. But since we know it can't be good, allowing high venous pressures to exist by iatrogenic giving of excessive amounts of fluid should be contraindicated in your practice. That's about as accurate an answer as I can give you.
Thanks a lot. Thanks for your very nice talk. And to close this session, I would like to thank my co-moderator and, of course, all our speakers for their excellent talks. And now you can enjoy the break and the afternoon sessions. Goodbye.